Hi everyone, welcome to tonight's Mind Matters webinar. My name is Yijuan and I'm host for tonight. So once again, tonight it's a small cozy group and we're talking about the topic of head or heart. What's the connection between these two when it comes to our mental health? Which one do we listen to? Is there a connection? So let's find out more and hear from our three distinguished speakers for tonight. Without further ado, let me just find out who's here with us in this room. So just indulge with me and type in the chat box. Let us know why you are here tonight. So you can type in a 1, a 2, a 3, and a 4. All right, so many of you are already here tonight wanting to learn more knowledge, strategies to help others with mental health issues. I think there's never been a time where people are actually experiencing a lot of mental health issues. So this webinar is brought to you by Breakthrough Academy and Therapy, which is a subsidiary of Architects of Life. This is our signature MindMatters series, where we bring to the public informative, educational information about mental wellness. So just a disclaimer, this webinar is purely educational in nature and is solely from the perspective and opinions of the speakers. It should not be taken as advisory, prescription, or substitute treatment of any kind. Before that, let's just look at the program outline first. So tonight is fully, we have a lot of activities packed inside, but stay with us all the way to the end because there will be a Q&A. This is where you can ask questions and engage in questions with the speakers. And we hope to end everything by 9:30 tonight. None other than Glenn Lim. Glenn is the co-founder of Breakthrough Academy and Therapy. He's also a breakthrough coach as well as a transpersonal psychotherapist. So without further ado, please join me to welcome Glenn. And over to you.
Thanks, Yijuan, and welcome to our current MindMatters webinar series. This is a masterclass where we feature psychotherapists, psychologists, psychiatrists, those in the mental health space to address mental health issues, well-being, as well as current trends in psychotherapy. And together with my featured subject experts here, John, Geraldine, we are part of the growing community of practitioners that are helping to address this ever since the pandemic. So MindMatters is a regular series, and this is probably our sixth or seventh webinar already. Every quarter, we hope to just organize a very short mini masterclass like this so that we get to be engaged with the community and also share our findings as well as best practices. My name is Glenn. Yes, I'm a transpersonal psychotherapist, which simply means that the way I deal with issues, counseling issues and psychotherapeutical issues is in a very holistic manner, existential in approach, meaning I believe in human potential. And so I believe healing starts with the individual taking responsibility over his issues. Today, we are focusing on the heart and the head psycho conundrum, meaning what is the disparity or some people call this a disconnection even. Is it really a thought in terms of the way we think and believe at the head level? Or is it mainly an emotional response to triggers and to situations? Or is it both? So I like to always come back to this diagram called the 3H Human Change Framework. In a way, I'm just setting up like the introductory form of the theme for tonight, so that straight after myself will be Dr. Geraldine and then followed by Dr. John, who will be touching more in depth to this psycho conundrum, and particularly for Dr. John Tan later on, because he's the national, and I would even dare say the Asia Pac consulting trainer for ASSIST program. ASSIST stands for what does ASSIST stand for?
Applied Suicide Intervention Skills Training.
Applied.
Yeah.
Okay, it stands for applied. Yeah, suicide intervention. So he's going to talk about suicide. Again, exploring the connection between head and heart. So this diagram talks about the human change framework. At the risk of oversimplifying psychotherapy, there are these three entry points, the three gateways to firstly to discover or uncover our issues, and then also to apply treatment. And they are very easy to remember because firstly, you've got the top part, which is the head, the cognitive domain. You've also got the heart, right? And of course, you've got the hands. Now, why do we talk so much, or at least for myself, I refer a lot to this 3H framework because these are your gateways or your entry points to deal or to address your issues, I feel. Yeah, it's a very simple format by which we can begin to see, okay, where do I first apply intervention strategies? Now, when we talk about the head, we are always talking about the cognitive base or the cognitive states. And therapies that are cognitive based are like things like CBT, cognitive behavioral therapy, cognitive processing therapy. MCT stands for metacognitive therapy. ACT is like acceptance and commitment therapy. And all these target rational thinking, very much talk therapy, which includes homework, addressing belief systems, faulty thinking. So it's very cognitive, right? But then also we have the heart gateway. And of course, that would be the emotional or the effective gate. So we have effective-based therapies like REBT, which are strains of CBT. Yeah, REBT is the rational emotive behavioral therapy. EFT, emotive or emotion focus therapies. Um, Dialectical behavioral therapy also deals a lot with the affect together with the cognition. We are human beings with emotions, and they do manifest or they are expressed, and sometimes emotions are like the gateway or the interpreter of what's going on inside, right? So therapists who work with the heart level or the effective level would typically address emotions, stay with them, and of course regulate them so that it becomes a bit more functional. We calm ourselves down and then start reflecting on what those emotions might be and what those triggers might have been caused by certain antecedents. So that's the heart level. And when we talk about hands, obviously we're talking about the body. So it's either behavioral, physiological. It could also be manual work, meaning touch therapy. So these are physiological based therapies like somatic experiencing. EMDR uses a lot of bilateral, so it's the eye movement desensitization, reprocessing. So you're using the physical eyes, or there are some tapping involved also, so meridian tapping. These are all very behavioral or physiological based psychosensory therapies. And in the last few years, particularly during the pandemic, this has become very popular because people were moving into alternative forms of therapy. And so movement-based therapies, yoga, mindfulness, this has got to do with this entry point using the body, right? So here you have the head, the heart, and the hands. Again, at the risk of oversimplifying therapeutical approaches, but I think it's a very neat way of understanding that there are some entry points by which we can bring about intervention, especially immediate ones, as well as, hey, these are entry points by which we can start doing the work. Obviously, we don't just stay at one level. We have to bring about integration. Part of my work in, for example, energy work, energy psychology, looks at the disintegration or the incongruency of these three states, these three domains. So for example, the head might have a particular new empowering belief of saying, hey, I would like to change my current state, my stress, my anxieties. But the heart usually, may go a different way. And maybe fear is still there, it's not addressed. And so you have this head-heart dilemma, right? And then what would the equational result be? Maybe the behavior might follow the heart more than the head. So sometimes you have this integration, this what we call even a fragmentation, where we feel split. We feel that we're not integrated. And usually it's, I use this framework to point out the fragmentation or the splintering between these three domains. For the purposes of tonight, we are looking at two of these domains, the head and the heart. So one of the things that we want to ask ourselves is when we encounter negative, maladaptive feelings or thoughts, where is it first caught or discovered? And then how do we address it? Do we enter the head first or through the heart first? And I'm hoping that this 3H framework can help set up our discussion for tonight as I pass the time to Dr. Geraldine. So I'm going to introduce her and then she's just going to take over. I do encourage all of you as you listen to us, listen to the speakers, take down your own notes because later on we're going to have a Q&A, a full-blown 15-20 minute Q&A forum. We're going to give you the Pigeonhole as a third platform where you are able to type in your questions or comments. We'll address those, we'll pick those questions up. Not only that, even if you don't have a question, you can go in, look at other people's questions, and then vote for the most agreeable ones because we are going to start with those. Yeah. Dr. Geraldine Tan is a principal clinical psychologist, and she has a team of counselors, psychotherapists that she operates from in town, actually in Orchard, quite nearby my office. And she's also the founder of this work called the Therapy Room. So she's been this for years. She's an award-winning psychologist as well, voted top 10 healthcare, professional in Singapore. So I'm going to pass the time to her as she delves deeper into the head or heart dilemma. Dr. Geraldine, over to you.
Thank you, Glenn. Yes, and I'll be receiving another award this Saturday. And when I say it, you will laugh because it's the 40 over 40. So now you know how old I am. But let me just see. Oh, I cannot click. Oh, yes, I can. Okay, so Glenn already introduced me, but I always have this slide because it's very, very funny. So my team will always put an exclamation mark behind my name, and then they have everything else, listed out. And I always find it initially very paiseh, to introduce myself and tell everybody the things that I do. But I do a lot of things just because I'm in this for about 20 over years already. But doing all these doesn't mean that I'm great. I'm just super ADHD, which then tells us that, I cannot sit still. So I'm very fidgety. And in my work, also, I am very fidgety. So that resulted in a lot of different things that I am doing. Okay, so today what we want to do is to look at a few things, our emotions in our brain or in our brain. You decide for yourself what is cognitive dissonance and how does it affect us and what to do. So I'm being a bit ambitious here. So let's try and see how much I can cover. Okay, let's go to our brain. So let me just, okay, so the brain have different parts as we already know, but the part that I really love is the limbic brain, where we always say we feel and then we touch our hearts, right? But actually, we don't feel from our hearts. We feel from our brains. So everything is parked inside our brains. Our body is responding to what signals the brain is giving. And there are different parts of the limbic brain, okay? So to me, it looks like a tadpole. I don't know how it looks like to all of you, but it looks like a tadpole to me. My favorite part is the amygdala, which covers the emotional responses. So there's a little overview here for how our limbic system looks like. And you see the other parts of the limbic system. That's where you take note that we need to help our bodies be in sync with, our emotions. So if you're hungry, you're tired, you're hot, you're cold, all these affect your emotions. Now you understand why, because it's part of the limbic system. And it is part in your hypothalamus. So that's one thing that, when we see our clients, and I do see quite a number of helping professionals here in the audience here today, the participants, and we always encourage people to sleep, to eat, to look after themselves. Why? Because all these will definitely affect our moods. So we always say, right, if a child is cranky, we say, oh, not enough sleep, or too tired. Similarly, for all of us, if we are deprived of anything at all, we do get rather cranky. So that's part of that brain there. And here we see, yes, the amygdala, my favorite part, it covers a lot of our impulse control, our emotional responses. And also, oops. Okay, my thing is not responding to me. Okay, it's responding. Okay, so yes, this part of the brain is very responsible. Let's go to cognitive dissonance. So we know that the head now keeps a lot of the information for us and tells us what to do. Now our body then either listens or does not listen. So when it doesn't listen, right, then we have things like it could be due to a certain disorder like depression, anxiety disorder, bipolar, schizophrenia, where the signals in the brain isn't functioning that well already, and the body is responding in a way that is rather erratic. But cognitive dissonance is slightly different. Cognitive dissonance is when you have a thought and two conflicting thoughts. Now, then what happens? Oops, I keep doing this. I'm not sure why. Two conflicting beliefs and you don't know what to do. So can we have cognitive dissonance in our practice? Definitely. So I was thinking of one that, and it's quite impactful. So I don't know how y'all would perceive abortion, whether you're pro-abortion or you're not, okay? So we all have our different belief system, but there was a couple that came to me. So along the years or in my years of work, I have different couples coming to me or even mothers coming to me and say, I need to have the abortion. So this particular couple, they came to me and they had to make a very, very hard decision to terminate a pregnancy because the baby is growing, but the baby's the DNA is not very good. So the child would be born with low IQ. There will be a whole host of different disorders, and they had to make a very hard decision to terminate. Now, in this situation, I was having a cognitive dissonance because on one hand, I'm pro-life. So I go, really, what can we do now? And I'm not sure how each of you would have reacted. But that cognitive dissonance was initially very, very strong within the mind. Okay, because it conflicted with my belief system. So when there is a conflict, we might then find it very difficult to manage the situation. Now, what that might lead to would be a whole host of different emotions that you might experience. So sometimes it would be guilt, sometimes it's embarrassment. It could be a mix of different emotions. Definitely, I was feeling a lot of discomfort in that situation. But it is not my decision to make. So how did I manage that? So if I had managed it in a way that it is I doubt myself, or I feel threatened, or avoid the situation, the story would have been very, very different. But these are some defense mechanisms that we might have when we are faced with a situation that goes against our belief system. And one of it is living in denial. Now, I think Dr. John will cover that, but many parents who have lost their children to suicide are suffering from cognitive dissonance. Whatever they believe, whatever that they have visualized or they had expected is now being thrown out of the window. And there is no way to find a balance back. So they do live in a state of denial. They blame themselves a lot. They question themselves, am I good enough? Am I not good enough? The avoidant behavior, we do see it a lot. The parents would avoid the friends of the past, even family members, so these are some behaviors that we see displayed when there is a dissonance. And we do see that in many of these parents also. Now, what then happens? So many of us are not in that situation, but we do have beliefs that are a little bit conflictual. So it does exacerbate some of our clinical disorders. Okay, so you see stress on the very left-hand side. So it starts with, I feel stressed. And stress is good, but when it gets to bad stress, it starts to hurt us. So our bodies feel the impact. It's no longer just the head receiving or giving out information. The body is not able to catch up, or the body is not able to deal with the information that is being transmitted anymore. And then you start to burn out. You start to doubt yourself. You have imposter syndrome. You feel a lot of dread. You feel a lot of heaviness. And it can morph into different sort of clinical disorders, including anxiety and depression. So there is a big shift in the cognition, and the body simply just gives way. So you cannot function anymore. So there was one current case, this girl. It was very, very interesting because she felt that she put in a lot of effort in a relationship, in a not quite a boy-girl relationship. So nowadays there are different levels in the relationship, and it wasn't even dating. It wasn't even like exclusive. It wasn't all these, yeah. It was just her looking out at a guy and then spending a lot of time playing a sport with the guy, and hoping that he would be her boyfriend. However, he then started to talk more with other girls and eventually started to ghost her. Now, she took that rejection very, very badly because in her mind, it's, I've put in so much effort, so therefore it would lead to something. So there's a mismatch in her real world and in her own quality world or her own perceived world. So there's a dissonance there. And it was so bad for her. She currently has very severe depression. Now, at the peak of her depression, she attempted suicide because she actually overdosed, and she overdosed on a very, very heavy dosage of many different kind of medicine and was rushed to the hospital. And when she woke up in the hospital, she was very, very shocked because she said, I didn't want to kill myself, but I could not control. So now she's even more angry with the guy because first she put in effort and then she was rejected. And because of him, she almost lost her life. So she has a very deep resentment for this person at this point in time. So her symptoms of depression actually is more severe than what you're seeing on screen at this point. There's not only the difficulty sleeping, eating, she can't even brush her teeth. And this is a really tiring chore for her. She doesn't bathe for at least 3 or 4 days at a go. So she will come for sessions with her hair, very, very oily, and she actually does smell because for the weather these days, it is rather hot and humid. So she would go out because we tell her to go out, but she will come home and she would not bathe at all. Yeah. And if you even attempt to talk to her, she would start tearing, she would start crying. Yeah. Because she is past that peak, she has no more plans or thoughts of suicide. And also because she's on a very high dose of medication. So that if the dissonance is left untreated or left undealt with, it can lead to clinical issues. Now, what then can we do? So you heard me say about the real world versus our perceived world over here. Okay, so it is part of CTRT, it is part of choice theory. Another theory, I think, given what Glenn's head, heart, and hands, I would park it under head because this also has a lot of different homeworks that they need to do or that you need to do. And we will see in a little while. So this is WDEP, a little framework that is used in choice theory to help your clients. So I did notice that many of you are looking for a little framework to use in your practices. So WDEP, a very simple way to help your clients to frame what they want, to ask them what is their quality world, what the picture of their quality world that is in their head, and then what are they doing to attain it. So an action that they are doing. Then the next thing they need to help themselves is actually to evaluate, which means to ask themselves, whatever that they are doing, is it helping them get to where they want to get to. Yes or no, then they can go on to the next thing, P, which is plan. Plan something that is achievable. So a very simple framework that you can use, WDEP, and you can help them look for, and what are they looking for? So usually the picture of quality life falls into, according to choice theory, five different areas. One is survival, the basic needs. Second, love and belonging. Third, power. Power meaning their confidence, their self-esteem. The fourth one would be freedom, their independence, their autonomy, if they want that, because some people do want it. And the last one is fun. So 5 different areas, and most of the time, so there are different people wanting different things or different degrees of the 5 areas, but most of the time, we do see that they are looking for love and belonging. So what are they doing to achieve that? Is it working, the evaluation part? And then the last one is, what can I do? How do I get there? That's the planning part. So yes, what we are trying to achieve from CTRT is so that they can take responsibility for their own direction in life, okay? Rather than externalizing, they take responsibility. So they use a bit more internal locus of control, and also to work on their relationship. Okay, so we do have Healing Hearts, a support group for bereaved mothers. So this is exclusively for mothers only, and is held every 3rd Monday of the month. And it is a hybrid. That means it's held online as well as in person. And we also have, because we are in this business of helping as many people as possible, I want to target the young ones to coach them on emotional regulation, emotional awareness, using different multisensorial therapies. I think Glenn was mentioning so many different sort of therapies. In addition to what he's mentioned, a lot more hands-on since it's children. We use a lot of play therapy, clay therapy, dance therapy, psychodrama, narrative work, movement. So there's an increasing demand for movement therapy, so different sort of movement therapy. And also, yeah, so there are so many different types of therapy that targets the hands part, which we can also use. So I think that's all from me. Hope that helped some of you. Over to you, Glenn.
Yeah, thanks so much. Let me turn on my video again. Thank you for giving all those insights, particularly the usage of choice therapy. I think that is one of those therapies that are being used in Singapore as well, when we talk about youth work, and is kind of a different branch from the gold standard of CBT, etc. But basically, I think not just trying to rely so much on our theoretical modalities. I think what's important is sensing where the person is at, both at his head state as well as his heart state. And so at this point of time, I just wanted to give the time to Dr. John. Dr. John is the consulting trainer of ASSIST, like I mentioned earlier on, Applied Suicide Intervention Skills Training. In other words, he's a trainer's trainer. He conducts a lot of trainer programs to help intervene, especially with suicide. He's also the co-founder of CARE Singapore, Children at Risk Empowerment. So this organization, non-profit organization, actually helps to run programs for youth, especially youth at risk. He's a dear friend of mine for over 3 decades. So that's how old we are. I wish I can say that I'm getting some award for being 40, like slightly above 40, but both of us are dinosaurs, if you want to compare that to Dr. Geraldine. So over to you, fellow dinosaur, Dr. John Tan.
Thank you very much, Glenn, for the introduction. Yes, I am a dinosaur. Thank you for just having this time with me. Though I will be touching a little bit on the topic of suicide. So just to kind of like trigger warning, I'll be talking about the topic of suicide, but more from helping us to understand the factors. I have a brief presentation, so I won't be covering every aspect, but just some aspects on the individual, helping us to understand, perhaps in the context of where does it reside in head or heart or even moving to the hand. So I want to put forth in trying to understand, some people like to say causes for people to think about suicide. Why do they think about it? I want to put forth as factors that affect the individual, right? So, and if I may categorize, then there will be 3 broad categories. So, and they go by, firstly, predisposing factors, followed by contributing factors, and then finally precipitating factors. All right, so these are all big syllables. I'm not so used to it, but maybe I try and define it in a more understandable manner. So predisposing factors simply means that these are factors that a person is already affected by, right? So it increases in developing mental health issues and challenges, and a person's risk level will increase in proportion to the number of this kind of factors that are present in a person's life. Yeah. So it's almost like saying, if I can use I think it's not a very good analogy, but analogy of, let's say, a person has a weapon, and this weapon is already shaped in that sense, then you have to tackle, or you have to handle with those kind of factors. In a while, I will show it to you, right? Then those are predisposed factors. You're already predisposed to it. And what will then make it even worse is when we have contributing factors. So contributing factors are elements that add to or exacerbate your predisposing factors. So it's almost like saying, if there's already a weapon, then the contributing factors are like the bullets or the ammunition that add on, right? And it still doesn't get fired yet until you come to the third level or category we call precipitating factors. And these are the triggers, right? So these it can be current negative life experiences, events, issues that directly trigger distress. And what does it do? This triggered distress to the point where the person is not able to cope, right? Loses the ability, or the ability is hindered or reduced. They're not able to cope with whatever is happening, right? And when these factors are not addressed, they perpetuate the distress, and they prevent the individual from returning to their normal state of balance. So it's when a person comes to the edge, right, being pushed to the edge, it's like, the proverbial straw that breaks the camel's back. Camels are so strong and hardy, right? But to the point where they cannot take it anymore, just a little straw can then push them over the edge. So in understanding a person who may be in distress and they start thinking about suicide, there are many, many factors that are involved in. So I want to share this chart with you and talk us through it, but a caveat, all right? This is only representing one perspective, one angle. It's not comprehensive. But put here, I'm presenting it here to help us to, deepen our understanding of how it may look like. One of these other caveat that I will always talk about and share with regards to suicide ideation or suicide behavior is that every case, or I mean, don't like to use the word case, but every person who faces this kind of challenges is in a unique and complex situation. It's not one size fits all. It's not a silver bullet to fix all problems, right? So it can come in a variety of factors. So maybe to help our understanding, let's start from the predisposing factors, okay? So if a person has attempted suicide before, then it increases the risk of the person completing a suicide in the future. The risk just shoots up, right? So a previous suicide attempt, because then they have moved from thought to action, right? Not just having it in their head, now they have somehow carried it out, right? So that increases. So that's the first predisposing factor that may affect. The second one lies in the area of where there's mental health, challenges or disorders via the form of depression, substance abuse, anxiety, or even other disorders. I must caution that says that not every person who faces these challenges are suicidal, and not every suicide ideation people are facing mental disorders, right? They'll make the distinction very, very clearly. It could be a whole, it's a combination of concoction of many, many factors going on, all right? One other predisposing factor with some people are, they are prone to hopelessness. Feeling hopeless is a kind of trait that a person may have. And some of them are afflicted with it. When you're afflicted with it, you already have a predisposing factor. Now, one thing I must also clarify, having a predisposing factor in one's life does not mean you are suicidal. Does not mean that. It takes other things as well. It's just that, you are already shaped and formed in that manner, all right? Or it could be a person struggling with persistent and enduring suicidal thoughts, chronic ideation for a long time, okay? Or perhaps even a history of childhood neglect, sexual or physical abuse. So this predisposes a person. It puts a person in not a good starting point. Now, contributing factors are the ones that then add the ammunition or the bullets to it. So it could be poor coping skills. Never practice, never rehearse how to, when bad things happen, don't know how to cope, right? Or they could just have very rigid cognitive skills. They're not resilient, they're not flexible. When things changes, they just cannot accept it. More like black and white thinking. There's no gray, there's no color. Or cannot tolerate when distress comes. They have very limited tolerance skills. They get triggered and upset very, very fast. And they have not learned how to overcome that or how to regulate it. And they do not know how to problem solve, right? They find it very difficult to solve problems. Or when they get onto other things like substance abuse or misuse, and that clouds their cognitive ability to cope. Maybe they think they can cope it, They use it as a kind of crutch, and then, but without that, they cannot operate. The next one could be impulsivity. If they're by nature impulsive, they're impatient, then you take action all the time, and very quickly, no patience and all that. It's a contributing factor to already a bad situation. All right, and if it's accompanied by aggression or even violent behavior, then they've learned this and they have not learned how to regulate. It's also another contributing factor. And perhaps the one more I would say is, I say this is not exhaustive list, but these are some of the more common ones when a person is plagued with anxiety or hypersensitivity, and they're looking around and they just look at the faces, they misinterpret that everyone is looking at them, everyone is talking behind their back or in front of their back. All this adds up. All right, so this added weight is somehow like just waiting for something to happen. That's the trigger. And then we move to precipitating factors. So when something bad happens, mostly it's a loss, and loss can cover a lot of things, particularly in the meaning they put to that loss, right? When that happens and they go overboard, they've been pushed to the edge. It could be that. Or they could be experiencing failure or rejection, or when they are victim of cruelty, humiliation, or violence. And sometimes this is like when people are being bullied, people feel they are being bullied, or they are being bullied, right? And this kinds of trigger, or when they suffer some form of trauma. Trauma in any form, it could be physical, it could be psychological, it could be emotional. That kind of trauma is too tough for them to take, and they cannot see any end to it. And all when they reach a health crisis. Now, this doesn't happen linearly. It does not mean that a person must go through all this. No, anytime, anything can happen. As I mentioned before, the caveat is that every situation that a person faces where there's suicide involved, it's very unique, it's very complex. And most times when the people that I try to help, and then in realizing the situation is always about not so much about them wanting to take their life, because that's such a huge decision to make, as it is more about they want to end the pain, they want to end the suffering, they want to end the isolation, but they don't know any other way to do that than to take that life. So I just want to caution that we sometimes want a basic formula that's very easy to quantify and to replicate it and then apply to everybody. No. So you will realize that how would you know whether a person has all this? It's only by listening, and it's by hearing that story. It's about understanding. And I always come to the point where a person who wants to suicide, I believe, has a reason. And there's a reason also why they are thinking about suicide at that particular moment. Was there a trigger when all? So we need to find out. Now, this is just one aspect, right? But the important thing is then to look, and I think it is in the theme of today's webinar, is that can we help? Yes. The protective factors for individual in that kind of context, these are the following, and this will be presented by Dr. Geraldine earlier, talking about when a person learns how to cope with whatever therapy, right? So learning coping and problem-solving skills. This can be learned, this can be rehearsed, so that it becomes learned behavior, so they know how to do it, right? Or when they have a willingness to seek or ask for help. When they are not plagued so much by the stigma or the taboo, that they feel judged, that they feel that nobody will listen to them, which is why the listening part for us as caregivers very important, right? So in order to encourage someone with that challenges to come up and seek or ask for help. Or if they maintain a good physical and mental health practices, that will be plus points for them that can kind of counteract even when they have predisposing factors, right? And when they are exposed to the experience and feelings of success, and sometimes could be very small steps, small successes, they begin to build their reservoir, of resource or internal resource. And when they can associate or identify with very strong, deep values, strong cultural identity and spiritual beliefs, although I must caution that sometimes the spiritual beliefs could be, a stigma kind of thing, a taboo, where people don't want to talk about or they perceive people with challenges to be weak, right? So got to be careful. You need to be grounded very, very solidly, and if they are living in balance and harmony. I thought it good to just share a few story experience that I have, and I count it a privilege to be able to do that. Just a few days ago, I just got back. I just got back from a conference in Calgary, Canada, and I met these two gentlemen. They are both called Kevins. Interesting, right? So the person on the right of me is Kevin Briggs, and the person to the left of me is Kevin Bhatia. And if you look at Kevin Bhatia's jumper, you will notice the word "Be the Voice, Stop Suicide." Now, why is this such a story that I need to tell you? Because I was so inspired by these two gentlemen. Because in 2005, this is what happened. So Kevin Bhatia, the black guy, the guy with the jumper, is this person on the bridge. And this is the Golden Gate Bridge in San Francisco. Every year, quite a number of people jump from there to their deaths. Survival rate for jumping from the bridge, very, very low. And the other Kevin Briggs, is that officer, California Highway Patrol or chief officer, whose duty, right, every day is to patrol that bridge. And part of the duty is to dissuade people from jumping. And on that particular fateful day, he encountered Kevin Bhatia. Literally, actually, in the sharing, they said he actually jumped, but Kevin, the cop, shouted at him, and mid-air when he was jumping, because Kevin Bhatia is a very athletic guy, he managed to come back. And there they were stuck for at least about an hour plus or 2 hours, just talking, processing. What was so important that Kevin Bhatia, the one who wanted people to know, was that he got there not because on a whim or fancy. And he shared that for the longest time he had been struggling with depression. But what was the precipitating factor? He was fired from his job. He was not given access to his child because he and his wife was going through a divorce, and he was in debt. He was struggling with that mental condition of his for a long time without knowing what it was. And so nothing was going right. And that's when he decided that he would, wanted to just end it all. Now, the fact that there was someone who cared and listened and talked to him. By the way, I must tell you that Kevin Briggs, the cop, is a trained negotiator. And he persuaded Kevin Bhatia to come back. All right, and so we see this was featured. By the way, the previous picture was actually one of the iconic pictures of this, and that was 2005. And today, okay, Kevin Briggs has retired from the force, but he went on to be an advocate together with Kevin Bhatia, who set up a foundation. So the point he wanted evil to go away with, and I was very, very inspired, which is why I thought, just have this story just to share with you, is that there's hope. There's hope when someone reaches out and just listen. Now, are there skills to be picked up? Yes, they are. All right. So, in a nutshell, I want to just end my sharing here today by saying that if you know of someone that you feel needs that kind of support, for us, yeah, it's a matter of going forth and just offering that and listen to them. Now, whether are there skills to be learned? Yes, of course there will be. All right. So with that, I want to end my short sharing and pass the time over now back to Glenn. Glenn.
Thank you, John. What an inspiring story to end your segment. And at this point of time, just a quick time check. We are right on schedule, where we are going to now move into the Q&A segment. Can cognitive dissonance be a positive force for change? So obviously, Geraldine, you need to pick this up. Not only this question, I think there are a few below that talks about cognitive dissonance, like here. Are there strategies to reduce cognitive dissonance? So maybe, Dr. Geraldine, you can help answer this on the topic of cognitive dissociation or dissonance. Geraldine, over to you.
Yep. Okay. So cognitive dissonance is not a bad thing, actually. It can be used in a very positive way. Like I mentioned, sometimes it is a point where you need to relook at your own belief system, or you learn how to be flexible. So if we talk about all of us, the learning process is let me see. I'm not sure if you all do your exercise and workouts, but I do know many friends who do like workouts, and they love to push themselves to the brink, and they feel very, very, very sore. So when they feel very sore, it's like they have, and Glenn is nodding, so you kind of know, right? You kind of hurt all the you cause little micro tears, I think, so that you can strengthen, you can grow, and during that whole recovery process, you get even better and even stronger. So cognitive dissonance can be also perceived in that manner, where you challenge yourself, you look at things from a different perspective. Maybe it doesn't really sit well, it causes a little bit of discomfort. What we do want to understand is that we don't want it to go into a space where you feel out of control, where you feel that you cannot deal with it anymore. So that's the part where we look at it's more than stress. There's burnout. You cannot catch it anymore. It becomes a disorder. So that's the part where we need to have a very, very fine balance. So it's just like stress. A little bit of stress is good. Too much stress is no good.
Thank you so much, Geraldine. Next question would probably be Dr. John. I think we can kind of lump this part, suicide, as well as identify and decide when a person needs professional help. Dr. John, over to you, maybe.
Yeah. The point about professional help, I believe very strongly in it. But because of perhaps the stigma or the taboo that surrounds even talking about mental wellness, mental health, and then we're still talking about suicide or even self-harming, sometimes can be so it can be so, scary that they don't come forth. So one of the very important point for us as loved ones or caregivers or friends or whatever is to have the concept of connecting and journeying with the person. Now, it is a courageous step even to do that, but it is more to connect with them as a human being and then point them out to a way that they can step forward for therapy. So I think is somehow in our own anxiety, we want to secure the person, if I may use the term, secure the person and say, like, you think about, oh, no, don't think it's not good, and all that. Like, I mean, I work a lot with young people, and can you imagine a lot of the adolescents that I work with, sometimes they go through breakup because, it's a very painful thing. Can you imagine what comfort is it if I tell the guy and say, come on, man, you are so handsome, there's so many thousand girls be after you. Cold comfort. It's not to, or even to discount or dismiss their feelings of maybe worthlessness or unworthiness and all that, but to replace it by saying, okay, yes, I hear you, help me understand why you feel this way, and perhaps we can go and look for help. So we, the point is we are not you. You know what I mean? So the we is just in helping them to know that let's go through this together, and then find someone who can give them the skills that they need. So to me, I find that yes, sometimes we can tell them all about the numbers. If you are suicidal, go and call 1767, etc., but they need to take that first step out, and they need maybe perhaps someone to walk through with them in that darkness. So I would say I come from the point of view that we are all humans, and humans need connection and relationship. So how do I help is I must take that time to journey with them. So that's from a very human relational point of view. Yeah.
Thank you, John. Geraldine, over to you. And this question, which has the most votes, but it's also linked to mental resilience. I think there's one or two other
Yes.
questions. Could you pick up this?
Wow. Okay. So we're talking about mental resilience. I think a lot of times parents are very concerned, how do I make my child mentally stronger, right? So this emotional resilience, and I personally would want to say that we want our children to learn about emotions. So I think in the past, we grew up, especially the Asian culture, we grew up believing that if you talk about emotions, if you emote, you are weak. But the contrary is true, where if you talk more about your emotions, you know more about your emotions, then you have a better grasp and better control over it. If you're clueless about it, you cannot name it, then you would not know what to do with it, because you will look at it and go, what is this alien thing that I'm feeling, or why am I behaving in such a manner? So this little incident that I often share, this teen. So I've got a very good rapport with this particular teen, many years ago already, but I always remember him because he gave us all a scare. And I was dealing with other things, and I was chatting with him. And then one day his mom says, Jerry, can you talk to my son? He's been in his room for days and he is not doing anything. Now, this mom catastrophized and said, is he self-harming? Is he taking drugs? And I had this sneaky belief it was something else. So I said, okay, as long as he's willing to come to my center, send him over. and I would talk to him. So he came over, slamming doors and screaming and shouting, but he still wanted to come and see me. Bless this little boy, this teen, right? He's actually taller than me, and slightly older teen. He came down, he sat down on my couch, and he kept quiet for the longest time. So I stared at him, right? And then I just observed him for a little while. He was very quiet. I said, "Sweetheart, what's wrong?" And he said, you made a sound as teens do when they don't want to talk. Then he couldn't share with me how he felt. He couldn't share with anyone what it was going through. So I said, okay, you know what? Auntie Jerry is going to hazard something. He stared at me. He looked straight at me for the first time in the session. And I said, "Sweetheart, you heartbreak, is it?" And he was like, oh. Finally, when I uttered the words, he could start sharing about how horrible it is, how broken his heart was, how he was rejected. And then everything came out, finally. It was like a dam that was released. But if nobody helps him understand how he feels, he wouldn't talk. People will be just accusing him of being sullen, being quiet, bad boy, rebellious, and just throwing all these stones at him. And guess what? We start to learn how to throw stones at ourselves. So we don't get stronger, we don't get mentally stronger by throwing stones at ourselves. In fact, we feel beaten down, we feel broken when we keep having stones thrown at us. So all of us should be invested in learning the language of emotions so that we can deal with it, so that we can start addressing it one by one. Yeah. So I hope that helps.
Can I share from a man's perspective? And from a dinosaur perspective. So this is obviously a parenting kind of thing, right? So I will put forth the idea that is by role modeling, and this is going to be very tough because guys, my era, we grew up to say, "Oh man, don't cry." And so what do we role model? We don't want to appear weak, but it is at that point where parents can show, so we go through tough times together, and when tough times come, it's okay to say, you know what, I feel afraid now. But then we go through it together because you identify, you give the language for it, you don't skirt around the issue. And then if you need to cry, you cry, because that's nature's way of relieving our own stress sometimes.
Yes.
And so we then tell them, right? It's not about, come on, you need to be strong. No, you can't. I don't know how to do it. You make the person feel worse because I don't know how to do it. But you show them, you role model. And I think that's the part where they see, wow, okay, so mommy and daddy can go through tough time and they come out of it. They come out of it, right? So I find that's has been helpful, at least in my situation. Yes.
Yeah, sorry, I got a bit distracted because my teen came and said good night to me. Yes, so I think it's you're absolutely right. The role modeling, I really love seeing when parents are able to dialogue with their children in a more emotional manner. It's more than the I love yous. It's the I feel and you feel, and it's okay that we all feel this way. So even in grief, sometimes parents say, "Oh, I cannot cry in front of my children." And I scratch my head and go, why can't you cry in front of your children? Because if you don't hold that space for them to emote, they will learn not to emote. They will learn to rein in their emotions, hide it, and barricade around it. So, Dr. John, you're really absolutely right there.
Yeah, wow, thanks so much coming from both of you, and then also addressing the head-heart dissonance thing as well. It's such a natural phenomenon. Jerry, Dr. Jerry,
Yes.
you still need to continue on this because a couple of questions regarding choice theory, relative therapy.
Yes.
Yeah, and particularly the WDEP model.
Yes. Yes. So WDEP is just a really small framework out of the entire theory. I thought I would just want to extract it. So it's very similar usage to our CBT. And I see a lot of you are trying to scratch your head there. But it's just more than that. So it's just one method to use. And if your clients are not ready to do it, or if you are not sure how to do it, then there are so many other methods. Please don't worry about it. Yeah, so besides the WDEP, earlier I talked about their perceived world and the real world. So how they have seen the world and how the real world is, and it may not match. So what we can then do is to help them to bridge these two worlds. So you can literally draw it out for them before using the WDEP. And that will give them a more visual perspective. So I'm not going to lecture about choice theory, but I really love using it, especially with the teens. Sometimes the schools have adopted CBT, so it gets very boring for them. So using a different theory kind of like disrupts their thought processes, causes that little bit of dissonance, and then learning will occur. Yes, CTRT is a course by itself. You should get certified with it. So there is the William Glacier Singapore that you can actually write into, and they will hold courses, I think, a few times a year. There are 3 different levels with different hours of supervision, and also a master's level. A diploma level.
Thanks, Geraldine. I thought maybe I'll just answer this one, quite related. How do we know what kind of therapy should we recommend to others? Well, first and foremost, if we are not trained and we are not in the industry per se, if you're just a loved one, concerned individual, then the best start would be to visit a registered counselor, a registered therapist. And then the therapist will recommend or make referrals, and we should take the lead from there. Yeah. So it's not for an individual unless you're trained in some form of counseling or even para-counseling. Still, you need to have a referral system, or at least work with the proper clinicians, and they will be the people to make the recommendations. Okay. Okay. John, I think there was 1 or 2 missed part, and this is a particularly detailed question. If a youth threatens to jump, are we to give in to her request in order to prevent real jump? Understand some will use this threat to get what they want, but being young. Okay, so we're talking about things like manipulation or maybe ulterior motives. Maybe John, you can answer this quickly.
Yeah. So sometimes on the flip side of this, I've always been some people share their fears about this as well, that attention-seeking behavior. So kind of like loping together. So they then learn that I cry wolf and then no wolf come, but my parents come, right? So then next time I can cry, maybe more wolves, right? So they learn their behavior. But I guess for me, I also come from the understanding that behind every behavior, there is a kind of desire or purpose that they want. And I will go towards finding out what is it that they actually want. But at the same time, to then de-escalate it, because impulsivity and high emotionality, the limbic brain is so powerful, especially in the teens. They may not even think about the consequence. They may actually, feel that they need to carry out whatever. So I guess the balancing part is when to need to de-escalate it by being calm and then say, okay, what is it that you really want? And then also at the appropriate time to then show up that whatever way they put forth is not an appropriate manner or a safe manner, to listen to their needs and then address the behavior later on, right? But at the same time, I guess, I mean, when someone threatens you something, your own emotions are in the fore, right? That is to protect yourself, and then the cognition part is totally gone. So I guess it's about us just being aware of how we feel ourselves, and then you can actually tell that, when you say this to me, I feel I was so afraid. And why am I afraid? I'm afraid to lose you. Just because you may not, and can we talk about it some more and try to understand where they're coming from, what are they seeking for, right? So I mean, if I approach it from that, of course we can be very calm now, but I can tell you when in that situation, you will be like, wow. And I always feel like, even when I do intervention, right, I mean, I always shoot out silent prayers first, because for wisdom, for knowing what to do, and then keep myself calm, and then to address it. So it's not about giving in to their request so much. That should not be our fear. As in, the fear is that they don't feel listened to, they don't feel their needs are being met. It's about readdressing that part, right? So we address the heart first, and then we address the head, so that then the hands will follow. All right, Glenn? So that's the conundrum that we try and resolve.
Yeah. Well, I do want to add, though, also that it's the same in a clinical setting, in a counseling room, right? When a person is emoting, for example, one of the first thing to do is to regulate the emotions, to calm the person down, because emotions really are this unpredictable creature, right? That kind of sabotages, maybe even hijack our thinking. Emotions are always stronger than logic, and that's why we first call of duty is to really calm down the person. The time has come for us to kind of end this webinar, but I thought maybe I'll just address this. Getting someone who's mentally down to seek professional help, often a huge barrier. How would you advise us going about it? One of my suggestions is, usually, if your parent, if your concerned family member, individual co-worker who suspects someone might need counseling but is reluctant or in denial, then sometimes I would say, why don't you come and see us as well, so that we can formulate strategies to help your friend or help your children or your loved one. Because you then become that first responder, that first contact person. And with the strategies that you're working or getting from the therapist, you could very well save a life, right? Okay, so that ends our formal masterclass. Do stay with me for just 1 or 2 more minutes, because we've got some announcement to make, as well as appreciation to our esteemed speakers. We're going to send you a link tree where you can get all the details, as well as the information there, the links. So firstly, it includes some of this, right? Complimentary psychotherapy consultation with us. You're free to just book an appointment, or at least indicate your interest on this link, which we'll send you later on. We do have basic counseling skills training, and it's fully funded, WSQ, Skills Future, credit eligible. So this is something that we are running just to support the community with para-counseling skills. I did say that I'm the developer of EDT, Energy Defragmentation Therapy. It is a therapeutic and training program. Again, we will send the link to you. Under Breakthrough Academy, we also run our signature Breakthrough NLP, Neuro-Linguistic Programming Certification, both at practitioner and master practitioner levels. So if you really want to unlock your vast subconscious potential for personal mastery and interpersonal mastery, this is something that might interest you. I do want to end off by saying that the next Mind Matters webinar, I'm really excited to host again Dr. Sunadas, who is one of those crazy people, right, who has 4 doctorates. Okay, and so we are going to talk about the energetic field, or what we call a biofield therapy, where each one of us as energetic beings, how do we utilize, understand our body's natural vital force for energy healing. So